Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Mark. How are you doing today?
I'm doing well, Dennis. Good to see you, and thanks for inviting me.
Yeah, absolutely. No problem. The pleasure is mine. It's been a hot minute since you were on our podcast last. Would you mind just doing a real quick introduction to yourself?
Yeah, sure. Mark Shapiro. I'm a trauma surgeon. I do acute care surgery, trauma, critical care, general surgery. And I trained in Cincinnati, and where I first got involved with the CCATs at the University of Cincinnati, worked with them in fellowship there. And eventually I made my way to Duke, where I was sent to Haiti and met a really very special person in my eyes, a friend of mine who was our security there. And he was a 18 series guy, and became pretty good friends with him. I had no idea about special operations. I came back to the U.S. and got involved with a DoD grant sponsored program, and working with operators, medics, and simulation versus live tissue. And that really got me involved, and eventually developed a medical proficiency training for the SF while I was at Duke, and then took that program with me to Atlanta, where I had them at the 18 Deltas at Grady. I was fortunate enough to be involved with all the groups and make some good friends, and that kind of brought me to working with the group at Ragged Edge, and now working as well, and for actually years now, with ground surgical teams in San Antonio, and developing their readiness as well. So that is the high-speed short story.
Nice. So again, lots of experience in trauma, specifically trauma surgery. So I think you're probably one of the better guys to talk to about this is wound ballistics. And I got to admit, I've kind of gone about the width of the spectrum, I believe, as far as I really need to know this, and I study this. And then the more experience I got, I started to become more cynical, and I was like, you know what? Metal hits me, and it just does what it does, and I'm just gonna take it as it comes, right? So, with all of the different, calibers, rifle, pistol, shotgun, IEDs, we've gotten very creative at how we destroy each other. How can understanding ballistics help me? Why does this knowledge even matter?
That's a great question, and I understand your cynicism, and that cynicism probably goes into it, but when you have that patient in front of you, it goes away, and you become, the best surgeon of any type that you can. I was training a colorectal surgeon for the ground surgical teams, and he had a gunshot wound to the chest, and he's like, "Well, expectant." Brother, you just had breakfast with this guy. This guy is not expectant. You are the best thoracic surgeon there is today, and that's my guess is that's how folks downrange feel initially, but then your training has to take over. And I think that's where all these programs, whether it's some of the ones that I just mentioned or others, to develop ideas, thoughts, practice patterns on the X. So ballistics is really important. It's important to understand and break down these injuries, high energy, such as a rifle and the type of rifle, a 50 cal versus a 226 is much different. And I've certainly seen them all in the civilian world where a sniper was taking down sniper took down a bad guy, and it blew his arm off. That's much different than a smaller round that's just made to either stop or potentially kill somebody, because that's basically what guns are. Guns aren't necessarily for target shooting; they are for killing, and they're very effective. So you can come up with immediate types of treatment and then develop that as the patient survives, and that's the prolonged field care about it. And if they survive initially, you got a shot at it, and I think that's the key. You just don't stop and mentally drown yourself with thoughts. You just keep working, a solution as this patient presents. Whether it's bleeding, it's fascinating. Some of these folks with these arterial injuries will not bleed right away with the vasoconstriction, and then they'll surprise you later as they warm up and their catecholamines tell their blood vessels you can relax now, and then it becomes a problem. So it's all about developing that paradigm beforehand, because when you're on the X, sometimes you don't think straight, or you just you become very narrowly focused and you miss other injuries. Because once that bullet, like you said, enters flesh, it could be a mystery.
Yeah. And I mean, that's why, we have March, we have A, B, C, D, E, F, and it seems like it just continues on the hospital side, to help kind of focus on, the important things that kill people early, and help kind of open up your aperture a little bit anyway. But breaking things down, okay, we already started to talk about high energy rifle. So maybe let's start there, and then we can get into low energy weapons, and then maybe explosives after that.
Yeah, so high energy weapons, again, we traditionally think of a rifle. We often classify that as, feet muzzle velocity, as in feet per second, right? So anything over 2,000 feet per second has traditionally been thought of as a high energy type of wound. And for those of you who enjoy physics, the kinetic energy that's dissipated is 1/2 times the mass times the velocity squared. And what that tells us is it's really the speed of the bullet that makes the biggest difference. So even though we've got a big, 50 cal round, the velocity of that missile traveling is really the big issue. But you cannot deny a high speed, heavy missile doing tremendous amounts of destruction. And many of us have seen those images or videos of the bullet coming near, say, a rock or a boulder. It hits the boulder, but it still kills the person, and it doesn't even hit the person. So that gives you an idea. The smaller rounds, which are probably easy to go on patrol with, the 5.56 rounds versus a 7.62, all that weight. I don't have to tell you, I'm preaching to the choir, but all that weight going on patrol can be very unpleasant. But again, it's the speed does kill. And so the other things with these missiles coming out of a rifle, usually it's a Spitzer type bullet. The Spitzer type bullet is that conical shaped missile, and that's made to travel far, decrease resistance and frictional forces and so forth. They're also made to tumble and yaw, meaning that the direction of the missile and the spin and how its orientation is in space is made to kill. And when that missile, or any missile for that matter, high energy, low energy, enters the body, the important principles are that that missile will fragment when it hits something like bone. Each particulate matter, whether it comes from the missile itself that has just been dissipated or a fragment of bone, when it travels, it can the diameter of that wound can be up to 3 times the size of that fragment. which means that a very high energy missile can fragment inside the body and dissipate up to three times the size of those fragments. That is an enormous amount of killing power right there. And so a slower velocity bullet may not fragment. It just depends, right? The Geneva Convention said it's okay to kill people. We just don't want to wound them too badly. And so came the jacketed rounds. And so the lead rounds, very soft, fragment very easily. The jacketed rounds, the brass around the lead itself, is supposed to stop that. But with technology as it is, we've developed faster rounds, more lethal rounds. And with that, we can easily follow the rules of engagement with a jacketed round and fragment the heck out of those and really create a tremendous amount of killing power. What does that mean clinically? Clinically, that means taking a round just about anywhere gives the potential for multiple injuries, and it is really hard to treat multiple injuries inside the body that have an unpredictable path. The old adage of, well, the small wound is the entrance and the large wound is the exit. We cannot say that. That is not a fair statement, right? So you can have a bullet that has yaw and doesn't hit the tissue at the very tip of that cone, that Spitzer type bullet, and so it goes in sideways, right? That's a possibility. Another possibility is that it hits the boulder and the boulder splinters and enters the body, right? The other possibility, and the more likely one, is it hits bone fragments, and a small amount of bone or particulate matter will spit out, and you'll see a small wound and a bigger wound. And when this missile does fragment inside the body, it stops. That's the idea. You don't want to ice pick your victim with a bullet. You want it to expand, mushroom, fragment, and create that stopping power. So as a surgeon, we're very careful, or we should be careful, of calling entrance and exit wounds. Should leave that up to the pathologist. We call them wounds, and then we investigate further when we go to the operating room, or sometimes we'll choose not to. One of the things that I heard, Dennis, and I think it's important to mention, because there's a great deal of truth to it, is that wounds to the right upper quadrant where the liver is, they don't need to be explored. That is not the message our audience should take away. The message when it comes to wounds in the right upper quadrant is that you can defer an operation, but that is something we do in the civilian world when we're able to see that there isn't ongoing pathology. Ongoing pathology can be like a blast to your gallbladder where it's constantly leaking. That is not somebody we would sit on. A not bleeding would be a very good reason not to go to the operating room. Sometimes it's contained within the liver itself. And then there are obviously very important structures nearby that if they're injured, you're going to take that patient to the operating room. Or interventional radiology. Nothing that you're going to do downrange, and without that technology, say if a roll 3, that patient probably needs to be explored. If they're stable, can you wait? And the answer is you might be able to, you might be forced to, right? Especially if you're near the X. It is not unreasonable in a stable patient to just take a deep breath and manage that expectantly depending on your resources.
No, that makes sense. So essentially, just if I can rephrase it, just so I remember, essentially,
Please.
if he's stable, don't screw around and make it worse.
That's a good thing.
Is that essentially
harm.
What you're saying?
I think it's reasonable. You have to put it all together, and that's why, an 18 Delta or, a corpsman has to put together their training and formulate a plan. And if they are stable, now I hate the word stable. I think we've talked about this before in your show. You can be hypotensive tachycardic and stable,
Yes.
right? That's abnormal and stable. Or you could be stable, normotensive, normocardic, and stable. And it is going to be a judgment call based on your resources and assets, right? If you do have a rotary wing, then maybe you do sit on it and just communicate that here's potential operative case. This is why we didn't do something, right? And the other thing is you might not be able to do something. In other words, a hole to the abdomen from around, whether it's low or high energy, it's not like you're going to pack them, right? That is a dangerous and unhelpful thing to do. And in large part, same for the chest. You don't want to cause a pneumothorax. You don't want to, put dirt in the chest. That's a bad idea. And although you feel kind of helpless, packing is probably not to be done.
Right. And I think that makes a lot of sense, especially if you're trying to pack the chest, which obviously is not a great idea. But I have definitely heard, I've heard instructors say it. I've heard students tell me, somebody has a gunshot wound to the liver. I'm gonna pack it from the outside, and that's gonna help tamponade off the bleeding. I don't know. As a surgeon who's probably seen more than one liver be shattered by a gunshot wound, how would you advise me to stick my finger in there and pack it?
Well, I wouldn't advise you to stick your finger. You probably push everything deeper into the abdomen. And those folks who have packed, it may not have been necessary, right? And you will get the anecdotal one, right? So what do you do when your patient's 80 over palp and clammy and sweaty and there's nothing left to do? I don't think anybody in their right mind is going to exactly. And to be honest, when it is in those type of extremis types of situations, you're also telling the team, I care. I'm going to do everything for you. I am not going to sit back and let this guy die without some sort of effort. And I think there's something to say about that. I think there is moral injury. You and I have seen moral injury. It exists. And I don't know anybody at your caliber or the caliber of the teams that are quit is just not part of the vocabulary. I don't think they ever had it. I think that's why they're selected. And so go for it. I don't think anybody's going to criticize you for that. But if the patient is quasi-stable, I would not advise packing.
When I finally do ask, like, where did you come up with this? Generally, it's always one story, and they only know part of it, because the story that they repeat, at least partially, the guy's had such a large injury, you could actually see his liver.
Yeah.
And they didn't pack it. They put gauze over top of it. And like that was the extent of the dressing that and again, like they were just trying, and it seemed better to cover it than leave it uncovered. So they did that. And, but like that liver is like this molded jelly that I would imagine if you start packing it, and like you've seen our guys pack wounds, like I can shove a lot of stuff into that tiny little hole. Like I would imagine you're more than likely going to just tear the organ even more.
Right. Yeah. I think that's a risk. Some of it comes with experience, which we know that if it weren't for MPTs, folks wouldn't get the experience. And then there's MPTs where it's a lot of shadowing and didactics, and but not a lot of doing. And I don't know. I think those are good for some folks and not others. And then there's the MPTs where you're doing, but you're not getting the education. You don't know why you're doing it, but at least you get the tactile and haptic kind of responses that you want. But you're not getting the education. And I see that at the risk of changing perception and opening up a can of worms. I've seen that with devices that people use a device and they say, well, I saved a guy. And I'm like, really? I said, did you really save him or did they not need it? And they get very offended by that. And I'm like, tell me, explain it to me. And as they're explaining it to me, I'm like, it doesn't sound like they needed it. I know you did it. And I know it helped at your, critical access hospital. I don't think, they were hyped, but doesn't sound like they needed it. They might have needed blood. And like, well, I stopped it. And, you can't teach that, right? My old professor, and chairman, said that just because it's a teaching institution doesn't mean it's a learning one. And some folks just can't make that leap and say, well, maybe you're right. So, getting back to our points, our critical points here, is I don't recommend packing a hollow viscous such as the abdomen or the torso. You're at risk for doing something bad. But I do recommend when there is nothing left to do and you've exhausted your mind and your teammates' mind, go for it.
Yeah. Yep. Absolutely. Like, I don't think I don't think that is going to decide the day. When you've run out of magic, by all means, go ahead. But let's not put that too high in the March algorithm there.
Right. I'd agree.
One other question. So we mentioned, identifying entry exit. So on a tactical level, that can be kind of important because that tells me which direction the guy was that did this. But on a medical level, does it even really matter? Determining entry exit?
Doesn't matter. With a single wound, maybe not. With multiple wounds, I do think it's helpful. But I think that determination many times, maybe most, is in the operating room. It's where you're doing the exploration. I always, I never say never and never say always, but I always try and figure out the trajectory prior to going to the operating room. I generally don't waste time with x-rays. I think if the patient needs to go, they need to go. And the x-rays and the workup and stuff like that, I generally try and do in the operating room. As a surgeon, being in an emergency department or, if you're downrange and you're on the X, get the hell out of there and figure it out on the way to wherever you're going. I mean, a roll 2 is better than nothing, and it's not a roll 3. So, be safe, be thoughtful, and create your plan as you're getting there. But don't waste time trying to figure out, which is entrance and exit. That at that moment, it doesn't matter. They're hurt between those two spots. The paths of a bullet inside the abdomen are, I wouldn't say they're definitely not predictable, but they're generally not too far away. And that being said, I recall a case I had where it was too far away. It just didn't make sense at the time. And if it weren't for an x-ray, which was done in the operating room intraoperatively, it made a huge difference. So
let me just get your thoughts, because sometimes, like you mentioned, once that projectile hits a bone, hits a fascial layer, it's going to take the path of least resistance, right? And I've seen gunshot wounds that just zip right through one side of the other. I've seen them hit a bone, hit a whatever, I don't know, divine intervention, how it happened, but it went around the body and goes, somewhere else, right? And the reason why I bring it up is I only can see what I can see. And, knowing, I guess, how, let's just keep it on like the chest, right? How do I assess? Because I see, injury to skin, some bleeding, maybe, kind of the adage of like, I have the MOI, a mechanism of injury, gunshot wound. Any signs and symptoms at all of a pneumothorax or hemothorax, like he's breathing fast, SpO2 seems weird, LOC is, altered. I'm doing needle D, finger Thor, chest tube. But
Yeah.
I've seen it go wrong where somebody did
Yeah.
chest tubes and they didn't need it.
Right.
So
I'm sorry, I don't mean to interrupt you, but a lot of these are absolutely, remember, this is the key thing. If the patient gets to you and they have a heartbeat, there's something you can do. And sometimes that something you can do is observation. And a key case that I had, and this is not to pat myself on the back, but this tells you how bizarre things can happen with these bullets, is this person, I'm going to try and be very gray, it is a court case. This person gets shot in the chest over the parasternal. It was actually, I think it was parasternal on the patient's left. And when I say parasternal, I think it was less than 1 inch from the sternum. Now, this patient is evaluated and treated in part at the scene, probably a little longer than many of us would expect. They deteriorate at the scene. They get chest compressions at the scene. They arrive to the hospital with the Lucas device, that's the automatic chest compression. And in my mind, when you have a gunshot wound that's over the heart, I don't understand the value of doing chest compressions, but there's protocols, civilian protocols. So the patient arrives with signs of life. He had a reasonable blood pressure. He was tachycardic. And when we took the Lucas device off and I put the ultrasound on the patient, and we were ready. I was ready to open up his chest and do a resuscitative thoracotomy and so forth. And I told the team, we mentally rehearsed who's going to stand where, how we're going to do it. This is what it's going to look like. We're not going to take the patient off of the gurney. We're going to go up to the OR if I do the resuscitative, all of that stuff we talked about. And lo and behold, the patient comes in as advertised with that wound, with a blood pressure and a heart rate. And I said, stop, this guy's alive. Like, there's nothing to do at this second. What we're going to do is we're going to transfer, we're going to hook him up, we're going to go through the ABCs, our march, whatever. And this guy was so quasi-stable, I took him to the CAT scan. Who does that? And when I asked a bunch of people, everyone's like, well, I do resuscitative thoracotomy. That was the plan. And I deviated from that plan based on vital signs and signs of life. And there is nothing that common sense should prevail. So took the guy to the CAT scanner, and it was a handgun. This missile passed just to the right of the heart, probably nicked the heart. When I say nick, I mean just nick. There was no hemopericardium when we evaluated him with the ultrasound, and it lodged in the patient's spine. They were expected to be a quad. Or a functional quad is what I should say, a functional quad. And there were some other things going on, but the point is that here's a gunshot wound that by all means, not only is in the cardiac box, it's like bullseye in the cardiac box, at least a 9, if not a 10. And by not doing anything, by observing, said a lot. And whether I was stupid and lucky or whether I was good and lucky, I have no idea that day. But on that day, that's what we did. And then the advantage of being at a regular hospital, my plan was to take the patient to the operating room. I did consult a thoracic surgeon. They didn't know what to make of it either. So our plan that night was take him to the operating room, heat him up, heat everything up, and do a formal echo, a high resolution formal esophageal echo. And we did that. We saw that there was really no damage to the heart. There was no hemopericardium. There was really nothing to do at that point. And we took that patient to the ICU and evaluated him. And I think the time was 6 hours. We were going to do a repeat transesophageal echocardiogram again to see if there's any changes. Any changes at all, we zip him to the operating room, open up his chest, and fix a hole. So there's going to be stories on both sides, Dennis, that we just can't explain. How does a bullet travel like that? I don't know. You're going to have to ask, a former president. You're going to have to ask, all these pundits. I don't know. But we will see time to time stories like one you were describing, and one that we often see when folks try and take their own life, where generally a low energy missile hits the bone and doesn't penetrate, but travels around the bone. And I've seen this a few times where people try and take a gun to their head. The angle is just so, and instead of penetrating the skull, it travels around the skull, under the skin, and out the skin the other side. And then most people would be convinced that there are two wounds, and it must have been a transcranial gunshot wound, and it's not. So follow your instincts, trust your training, ask questions. It's okay to have some self-doubt, but if the patient is telling you that they have a blood pressure and a heart rate, and even better if they have a mental status, that's great. But it's hard to put a hurt on a patient who has some stability there. At least it gives you a second to okay, they're okay for now. What is the plan? And when that plan fails, what's the next plan?
Mm-hmm. Yep, absolutely. Always have a plan and a backup plan for that one. But we already started talking about, low velocity wounds. Yeah. So I guess obviously other than speed, kind of what is the difference in how they traverse through tissue?
Yeah. There's target rounds, there's the jacketed rounds, semi-jacketed, and then there's the rounds that are made to either fragment or like the black talon, split apart and create like little knives going through. Nothing will replace rounds on target and multiple rounds on target. You have gun experts in the community that can probably tell you way more than I can. A trauma surgeon isn't necessarily an expert in any of this, but whether you're a 45 guy, a 9, a 10, that's in large part a personal preference and a skill preference. But the type of round does make a difference as far as how much it'll mushroom, how much it'll fragment, and how much it'll split apart and form these leaves. They're great weapons for killing. Stopping power and killing power probably a little different, but in the end, it's rounds on target. How do they behave in the body? Not that differently, based on what we just talked about. I don't know that that's gonna make a difference. You're gonna explore. You're not gonna pack. You're gonna get them to a surgeon or a medic, and you're gonna treat as the patient demands.
Also, like shotguns are becoming a lot more popular now in the battlefield. Before we were just using for generally just breaching was most of it, but now with drones and things like that, so I imagine birdshot is going to be something we're going to see a little more frequently, injuries from something like that. So what about shotguns? I mean,
So shotguns are great weapons for what they are, meaning that they'll get your attention. And the closer you are to the target, less than 5 meters, between 3 and 5 meters, they are absolutely lethal. The farther you go out, it's not much more than a mosquito bite, depending on, what rounds you have, whether it's birdshot or a deer slug. And one of the things to dispel, we talk about how the spray of a shotgun, for I think it's 1 inch and 1 foot, every inch, a foot of dispersion occurs with birdshot. I think there's enough, they're not really even studies, but enough evidence, enough people have looked at it, and that's not exactly true. So we can't necessarily go with that plan. But what I will tell you is that as a trauma surgeon, it is a miserable injury to take care of. And especially when the birdshot gets in the abdomen and there's multiple injuries to the small bowel and fistula. And so shotgun wounds create a mess. They really do. They are the injury. They're like a mobile IED. In other words, especially when you're using things like buckshot and birdshot, these little fragments go places that in general we may miss, the human eye, and they drag in clothing and they drag in all kinds of debris. And it is a infectious nightmare. So fistula is an infection. The amount of tissue destruction. Remember, when the energy dissipates and it injures blood vessels, then it devascularizes tissue. And as it devascularizes tissue, you can give the patient all the antibiotics you want, because antibiotics only travel in the bloodstream. And when you are devascularized and the antibiotics can't get there, and the surgeon has to continuously debride it, you are working against time. And so that is why shotgun wounds are a completely different animal. I treat them way differently, and it is often kind of a daily trip to every 2 days to the operating room, making sure that you don't miss anything and trying to stay ahead of infection without debriding live tissue that you need to heal, because that's really all you're doing, is creating an environment for the tissue to heal. Wound vacs have really helped with that, but they're not the cure-all. And I can remember a shotgun wound that survived for well over a year on TPN, and multiple trips to the operating room and multiple attempts to keep up with his fistula. He ended up having short gut, and it took him a while to die. That was a horrible kind of death. He became the hospital mascot. Sweet guy, innocent guy, but it was just bad.
Just too much.
Yep.
So also, I guess kind of in the similar kind of realm as the shotgun blast, we have our IEDs.
Yeah.
Right. And obviously, the closer you are, the more destruction you can get. One thing, especially, I've been hearing a lot, like Ukraine, and it's going to start getting colder now, so the ground itself gets harder, and those like artillery mortar shells, they don't actually penetrate into the ground; they just explode on top of the ground. Just because the ground is so hard, right? So it kind of changes wound patterns, and they're getting a lot of like large tissue disruptions. How from like a wound ballistic side, like how do you handle something like that versus the guy is a little bit farther away and he just gets peppered?
Well, some of these wounds are somewhat predictable. They're all kind of devastating. Things that come into play: one, is there blood supply to the distal tissue? Two, is there a nerve supply that's intact to the distal tissue? And then is there structure to the soft tissue? In other words, is the bone broken or not? Is it a simple fracture or is it a complex, fracture? And then what is the time to repair, right? And so if we, there's the rule of thumb, 6 hours for devascularization, but that's from time of injury to the time where blood flow is restored. And then are you able to, it's one thing, you got to get blood in, but you also got to get blood out. So venous injuries can be really rough. A lot of times with venous injuries, you're just tying things off. And if you have multiple blood supply, say to the ankle, you can tie a couple arteries off, but you can't tie all three off. And so these are all decisions that you'll make, somewhere else. So the rule of thumb, for the most part, save as much tissue as you can. Plastic surgeons, microsurgeons, vascular surgeons all have a shot at it if they can restore blood supply in a reasonable time. I've seen it. This does not mean it's right, and I'm not advocating for it, but I've seen a vascular surgeon restore blood supply to an ischemic extremity more than 7 hours out. Ultimately, it failed. That was very predictable. I don't understand why that was done. But it can be done, and maybe it's just asking the question, and then there's folks who just want to get on with it, right? Take my leg off, let me get on with rehab. I'll live with a prosthetic, and they'll do amazingly well. They're not in rehab for a long time, and they're living a normal life, There's always the one, right? The one, I can't remember if he was an SF or a Ranger, but he came back with a prosthetic, right? I mean, American hero. And I think that's great, but not everybody's going to be that person. And it just depends on, mental and physical altitude, if you will, on where you're, what you would want. So evaluate it for nerve viability, vascular viability, soft tissue viability, right? All of those things can be intact, but you have no soft tissue coverage whatsoever for a segment or a small segment. That there's going to have to be some type of tissue transfer. And so, again, none of these things need to happen on the X. So get the extremity to extension and try and preserve. There's going to be some vascular compromise, whether it's spasm or disruption, and then evaluate it later.
Okay. So, I mean, obviously on the X, I promise I will not be doing any of these checks, but, once we get to more of a clinic and I'm thinking, hey, within 6 hours, we're going to have to kind of do something. Like, we can't just sit around, checking, vascular supply. That seems fairly simple. I can do cap refill checks. I could get an ultrasound and do some kind of Doppler. There are things and I have education to do that. Neurovascularly, I'm not really certain, because, the patient already has some kind of analgesic on board that's altering, whether he can tell me, he can feel this or not. So how would you assess neurovascular function or neural function?
If they are conscious or unconscious. So if they're unconscious, right? So conscious, right? It's just your physical exam. Can you feel this? Can you move this? Do they follow, the commands for mobility, things like that? And then your vascular exam, the 5 Ps. You go through that algorithm. Do they have? Is it pulse palpable? do you just get a signal? Do you not get a signal? Do you have pain? What is the color of the tissue, that you're examining? Is it warm? Is it cold? That can be, so you go through your physical exam. If they're not conscious, we try to err on the side of preservation. And you say, okay, it's not a great exam. It's the best I got. Now, if it's blanched, it's white, and they don't have to be awake for pulses or signals. If there's absolutely nothing, there's probably not much you can do. And you may want to think about a tourniquet proximal to the injury.
Nope, makes 100% sense.
Right.
Anyway, again, so up close, like you said, massive tissue destruction. You got 6 hours to kind of sort it out. If you're going to do something or pass it out.
Yeah, let's just, I just, if I may, try and clarify that a little bit. You don't have 6 hours to sort it out. You probably have about 5 hours or 4 hours, because at least in theory, you want that revascularization. That means they're in the operating room, everything's set up, and there is flow restore. You have your anastomosis, in theory, around that 6 hour margin. Is it 4? Is it 7? I don't know. You got a young, healthy dude, it's probably going to be closer to 7. But the idea is that, somewhere that operation has already commenced.
Yeah, at least the operation commences within that 6 hour window. The decision to whether you're going to hold them, whether you're going to push, that's got to happen a lot earlier. And I'm assuming, which I should never do, resuscitation is going, like we're doing all the life-saving things. Now within that 3-4 hour mark, we have to make a decision. Are we going to, prepare this patient for an amputation, or are we going to try and push him to somebody else to, save the limb, kind of thing?
Right.
And the longer you wait, the more likely you're not going to win.
Correct.
Yeah. So that's close to some kind of IED or some kind of explosion. Is there a difference between like a purpose-made munition, like an artillery round, mortar round, versus like an IED?
Well, you bring up a really, really good point, because IEDs and landmines, things of this nature, also have a large degree of unpredictability. The predictability may be the pattern of injury. In other words, a dismounted patrol, one of the common injuries we see is one leg gone and the down arm on a rifle, right? So the non-dominant hand is extended. The dominant hand is somewhere around the trigger. And when these blasts occur, they take out the one leg and the one arm. And that's kind of that gives you an idea what the injuries are and where it's coming from, and the trajectory of the fragments. And so these fragments can be like way up in the pelvis, even though the ankle and the knee are all destroyed. These high energy fragments can travel very far, which means injuries to colon, bowel, sepsis, you name it, bladder injuries, the mortars or munitions, and some of these other type of aerial bombs, I guess you would describe it, right? So the things that matter with those is where they were detonated, right? So a breaching munition, I always think of the Carl Gustav, because you can, it can be in the air, it can be at the door, or it could be inside the door where it goes off. And when these types of blast injuries occur in a closed room, that's often a very different injury. The movies make it so you can go in there and talk to the patient and figure stuff out. And there are no eardrums. There's no talking. You're working with hand signals and, your mouth. And trying to articulate some information, and so those are fairly unpredictable munitions when they detonate, and when they we learned from the hulls of the vehicles the patterns of injury that occur there, right, with the old H1s versus the new vehicles with a boat-shaped hull where it dissipates that energy. So different injury patterns with those, and but it all gets down to the fragments, where the fragments are, how they're treated, getting antibiotics in as soon as you can, and then treating everything expectantly.
Yeah. So maybe outside of that blast zone, right? You still have shrapnel that can definitely travel some distance, and those also, causing your just penetration type injuries, and all these shrapnel pieces can be of all various sizes. I've seen like car doors swing by, and I've seen stuff that's like essentially birdshot come through. So like, is there any kind of predictability? Is there any kind of change in treatment with
so I like
some
this
distance?
question, yeah, because I think what you're getting at, which is good to direct me, is the anatomy of a blast, right? So the anatomy of a blast, a munition is detonated. The primary blast is the concussion wave, right? It's that very sexy looking thing that a few people have on film that shows you this overpressure, this blast wave. And that blast wave can create all kinds of problems. It doesn't have to be an IED. It could be a tanker. I had a patient who was near his tanker blasted when he was using he had a propane tank, and he's using a blowtorch. And so those types of injuries like that can create bowel injuries, which is the most commonly missed injury. These bowel injuries, I've argued back and forth with biomedical engineers whether the blast injury itself, the concussion wave, blasts the bowel and they have free air and they're sick from that, or does that concussion wave travel through the open mouth, through the aerodigestive tract, and then explode your bowel from the inside. So there's that injury. The other injury, the small ossicles of the ear, for instance, we just talked about those. Very sensitive to that concussion wave, and blast your eardrums and you can't hear. And then what's a really hot topic right now are traumatic brain injuries. I know Ricky Ditzel is really kind of on the forefront with a bunch of other neurologists. I just know Ricky and his passion for it, but there's a lot of people looking at TBIs with this. And then the other injury that can be very obvious, and that's a lung injury. And so you get this spalling, you get this direct injury to the lung and the alveoli from that blast wave. And so hypoxemia and injuries to the lung itself are extraordinary from the blast injury. The secondary injuries are the patient being thrown, against a solid object. And those are more kind of soft tissue, kind of head injury, bruising, and maybe broken, something. And then the tertiary is the one you described, these fragments. And these fragments, probably more downrange than here, are sometimes coated with fecal matter, poisons, whatever. And as they drag, the dirt from the ground and so forth through your jacket, through your vest, into the body, create horrific infections later. And but as far as can you determine where they are, the answer is no. Whether they're marbles or screws, you pick the fragments in there. That's unpredictable. And then finally, the quaternary type injuries, and these are your biologics, chemical agents, and so forth, that can also be part of it, whether it's aerosolized or painted on the on the fragments themselves. These are the injuries that you can get. And again, it's not all that predictable, you know, which way the wind is blowing and which way the device is shaped for the fragmentation. That can give you some idea, but where they travel and how far they go in the body it's not that predictable.
Yeah. So I guess obviously you've spent a fair amount of time studying and learning about these things. What benefit in your career have you gained from this, you know, studying wound ballistics?
What have I gained? I think it's all reps. The more you see, the less you rely on what you were told to do, and the more common sense takes over, which really brings us full circle to something you said in the beginning. It's not that I keep saying rely on your training, but your training should include use common sense. If the patient's alive and they're talking to you, use communication. If the patient's not talking to you, use the fact that they're alive. And take a deep breath. Some of these folks, unfortunately, are just going to die. And give it your best shot, whatever that best shot is. But there's more coming. And you're working in a resource-depleted environment. And what you are trained to do is to make these very heavy decisions in a very short period of time. And you're going to fail. It doesn't mean you failed your patient. It just means that God had different ideas.
Yeah. Well, thank you, Mark. I really appreciate you coming on.
Dennis, it's always a pleasure. It's great seeing you, and hopefully I'll see you in a week or two.
Yeah, absolutely.
All right. Well, thank you again.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.